Okay. Anybody aware of any other apologies? No, I think that's just the two. So, Chair's business, can I just thank the representatives from the independent care health providers who attended the urgent briefing that we had with the committee on Tuesday, the 27th, focusing on community care and patient flow through hospitals. So I think that was very useful and informative, and will obviously help us when the committee looks forward to meeting with the Permanent Secretary next Thursday at the Shankill Women's Centre. And certainly we'll be raising a number of the issues that we heard on Tuesday at that. We're trying to get to the bottom of hospital flow, and these two engagements are obviously very important. Can I also extend my thanks on behalf of the committee to the staff at Antrim Area Hospital this morning, who kindly accommodated us and gave us their assessment of the impact of the pilot wearing body-worn cameras for some of their staff. So that today's visit did provide valuable insight into how the integration of body-worn cameras is supporting staff and helping reduce incidents of violence and aggression against healthcare workers. So I think we were all very, very informed by what we heard and saw, but more importantly, informed about the impact that this pilot is having, both on the confidence of staff, the reassurance felt by staff. I mean, I was particularly struck by the nurse Emma Marie when she said it's actually not just staff, that an 85-year-old patient said, I'm glad you're wearing that camera because it now makes me feel safer. So I mean, we shouldn't have incidents of violence and aggression against staff. We're trying to, as a committee, to reduce that and do whatever we can to help reduce that. Clearly the pilot is now finished, so if members are agreeable, I would suggest on the back of our visit today that we write to the Minister just alerting him to the fact that we've had a visit, that we were impressed by the pilot, and notwithstanding any kind of public consultation that's necessary in the process, that we would like the Minister to use his office to ensure that there is a speedy progress of this particular issue, and that staff in other trusts and in other areas of our healthcare sector may potentially get use of this and have the benefits of what we heard during our visit today. Everybody happy with that? Okay, thank you. Draft minutes. Can I refer members to the draft minutes of the meeting held on the 22nd of January, page 42 of the main pack? Everybody content? Matters arising? None. So we're just moving on then to item number 7, which is briefing on the Adult Protection Bill from the Western Health and Social Care Trust. Can I refer members to our papers at page 54 of the main pack? And representatives from the Western Health and Social Care Trust are going to be joining us remotely this afternoon. So can I welcome via video conference Dr. Tom Cassidy, Director of Children and Families and Director of Social Work, Mr. Stephen McLaughlin, Assistant Director of Social Work, Learning Development, Governance and Adult Safeguarding, Miss Laura Coyle, who is Acting Head of the Service Adult Safeguarding, and Mr. Gavin Hamilton, Chief Social Work Information Officer, and also Encompass Social Work and Social Care Professional Lead. So thank you very much. You're all very, very welcome. I'm going to hand over to yourselves just for some brief opening remarks, and then we'll take questions from the members in the room and online. You can hear and see us okay?
Yes. Can you hear us okay? Yeah.
Yes, that's good now.
Okay, thank you very much. Thanks for the introductions. My name's Tom Cassidy, and I'm the Director of Children and Families and Executive Director of Social Work. And as you mentioned, we've got my colleagues with me. What we thought, if you don't mind, is if I pass you over to Stephen McLaughlin, who's our Assistant Director with responsibility for adult safeguarding. He'll maybe just do a quick synopsis for you of our response, if you would find that helpful.
Yes, go ahead.
Okay, thanks. Well, Stephen, over to yourself.
Thanks, folks. Thanks to the committee for inviting us to give evidence. As Thomas said, we're glad to be here, and we welcome the Adult Protection Bill and how it will further safeguard adults at risk and those who have experienced harm. There will be challenges, which includes finances, workforce, and the complexity of managing cases, including managing the subtleties of capacity and consent. We welcome the bill putting adult protection on a statutory footing. This will improve the consistency of practice across Northern Ireland. The powers to intervene and the powers to hold the account where harm has occurred are welcomed. The principles of prevention, autonomy, empowerment, dignity, proportionality, partnership, and accountability are critical to how we take forward this legislation and will provide the basis for protecting those at risk. And will also bring about professional complex challenges that social work is best placed to manage. The definition of adult at risk is central to the bill. The continuum of safeguarding through to protection is everyone's business. It is critical that when the thresholds of harm are met, that adult protection services are able to respond in a timely manner and ensure effective protection for those who need it. Muckamore and Dunmurry Manor have taught us this. We will all have to communicate effectively in this matter and highlight that there are already a range of services better placed to deal with other safeguarding concerns, such as self-harm or self-neglect. The duty to report and the subsequent responsibility and the trusts of their duty to make inquiries will have a significant impact on statutory agencies, which the business case does recognise. CCTV is useful, and we recognise and understand why this is so important to families and loved ones. But it is not a silver bullet and will bring challenges as well, including dignity and privacy issues. CCTV should not be over-relied on to protect adults at risk. Unfortunately, to date, it has been used more to prosecute after the harm has taken place. We need to work proactively with service providers to ensure that we have a culture of high quality care where harm happening is an exception and reported and dealt with effectively and quickly. It will ultimately be this that ensures the best safeguarding to those who need it. The oversight of the quality of care by families, care managers, and the regulator will be of greater value to protect than CCTV. There will be environments where CCTV is simply unacceptable. For example, in supported living arrangements where the adult service user is the tenant. And finally, we are conscious of the challenge faced by all of us in terms of implementing the bill from a financial and resource perspective, which includes the workforce. All stakeholders would prefer to implement the bill in its entirety from enactment. In the absence of this, we will work with the Department, SPPG, and other key stakeholders to manage a phased implementation that will bring meaningful safeguards to those who need it. Thank you.
Okay, thank you very much. Thanks, and also for your providing the written briefing in advance. So, I mean, just when you were finishing there, you were talking about sort of phased implementation or your preferred option of implementate all at once. But we've asked, or the committee probably has concerns about the resources of the bill. So we may get legislation that doesn't have the required resources. Therefore, there may need to be a phased implementation. So your evidence is suggesting that there could be an impact on workforce. So you finished in that. So some of the things that you're saying in relation to workforce, so their trust will probably require additional staff in terms of managing the additional workload. Then the bill will, caused by the introduction of the bill, there's also the danger of increasing demand for senior staff in adult protection, especially in social work, and that may cause depletion in other areas of social work. And I mean, there was a number of issues on there with regard to impact on your workforce as well. So I'm just wondering, are you working in preparation for the implementation in the bill in terms of building your workforce and building resilience within the Western Trust for the implementation of the bill?
Maybe I'll just take that initially, if you don't mind. I mean, we have within the Western Trust, a workforce strategy which is really focused on, recruitment and retention in its generality. But if you're happy, if I could pass to my my colleagues maybe with some more specific issues in relation to the Adult Protection Bill. Stephen, are you happy to?
Yeah, and just to carry on from that, our current workforce retention strategy has largely focused on, in the last couple of years, dealing with some of the vacancy issues that you will be aware of and that we've seen across children's services. And we are in a better place, and that is included with the work with the department in particular and how we've recruited students directly from universities, the extra places commissioned at universities, the places commissioned at the OU scheme. And we've piloted a particular model in Enniskillen. We're in a better place now than what we were 3 years ago. We would still have some concerns if this bill was implemented in its entirety tomorrow about the number of social workers we'd have to recruit in the adult safeguarding to fully implement all the duties and powers. And will that have an impact then on our services where social workers could be recruited from? We have been told that that'll be a phased approach, and that will include how we manage the workforce issues. So that's where we will be wanting to work meaningfully with the department to try and manage all of those concerns. We can't have a situation where we lose a number of social workers from one area where they're needed, such as children's safeguarding. But I think we have to manage that pragmatically as well and work through those issues slowly.
Okay, I mean, that would be a concern that we're kind of robbing Peter to pay Paul and the other services. So, I mean, that's something we'll obviously take up with the department. Sorry, the other issue of staff that was in my head to ask you at the same time was, I mean, you've talked about the CCTV issue and the fact that the introduction of that might make staff reluctant to work in challenging environments where there may potentially be CCTV. I mean, is that a concern that your staff have raised with you, or that people have raised with you, and something that you've raised with the department?
Maybe that's Cap.
It's definitely something that we are paying attention to. The issue of CCTV, I know you've heard lots of evidence about it in your committee over the past couple of months, and you've heard about all the different complexities associated with it. We do anticipate that it's going to create challenges for our staff. It's a sector that we already face difficulties recruiting into. We know that these are quite low-paid jobs, and we know that we don't want to create any more challenge in that arena. So we anticipate that there are going to be challenges for staff, knowing that CCTV is around for them. We don't believe CCTV is the thing that keeps people safe. We believe our people keep people safe, and a safe culture keeps people safe. So we don't believe that focus on CCTV is all that helpful probably within these situations, but we do think it would have an impact on our staff, yes.
Okay, thank you. I'm just going to go to the other members. Nuala?
Thank you very much for that. I have a follow-on question with regarding the workforce issue, and maybe it's I've just not understood it properly, but I understand that there will be a greater emphasis on workforce to kind of carry out the full implementation of this bill, and there was a lot of mention of children's services. But when I think of social work in particular, there are two distinct different roles, are they not? Do we not have adult social workers and children's social workers? The training is different, the qualifications, the places. So I'm just not sure how. I don't understand why children's was mentioned. Is it more than the social work side? And what impact that is, if you could just explain it again. Or maybe I'm just thinking of it solely as social work and there's other issues. If you could just kind of explain that for me.
No, apologies if I've left you with any misunderstanding, but the first thing I would say, there's only one pathway to qualification in social work, whether you go and enter into children's or adults afterwards. It's one pathway through university. You don't qualify as a children's social worker or an adult social worker.
Okay.
After you qualify, you can go into either area, which most people do. So the reference to I was making the children's social work is we've done a lot of work in addressing our vacancies in the last couple of years. We've been supported by that with the Department of Health and the work that we've been doing with the universities to fill those vacancies. And yes, there has been additional funding for additional places at university in preparation for the rolling out of the MDT project, where social workers will be part of, and starting to think about the adult safeguarding legislation as well as our legislation. And we continue to work with the department to think about the numbers of social workers that we need qualified to implement all of this work.
Okay, that's my misunderstanding, and that helps me to understand that a bit better. But just then following on from that, we have said this before regarding the MDT model and the shift and movement of social workers. But will this new adult safeguarding bill require a greater level of experience? And therefore, will you be taking your current experienced social workers, and will they not come from the adult social work sector? You know, are they different or not? I'm just wondering how we can kind of protect one, but not at the cost of another.
And protecting one without having an impact on the other is going to be very complex. Ultimately, the bill introduces the idea of an adult protection social worker. Currently, our adult protection social workers are designated adult protection officers, and they're at a higher grade than our children's social workers typically. This will create further, more senior opportunities within adult protection, which we anticipate will be more attractive to our child protection social workers. So what we think would happen, and what we've seen happen through the through the introduction of the multidisciplinary model, was that our experienced staff who have maybe been qualified for 3, 4, 5 years and don't see as many maybe band 7 opportunities within their service area, they see a more attractive post within potentially adult protection if the bill is introduced as it is, and they would then move over into those posts. We won't have control around selecting only staff from adult services, for example. So that is our worry about the implication it could have for our other services.
Okay, I'm glad I asked that question, because I think that is important then for seeing how the department might seek to protect children's services, because we know with the Ray Jones review there's already been a crisis in many areas. Moving on then from that issue, my other question is regarding in your written submissions you talked in terms of the experience with the Mental Health or the Mental Capacity Act, and we have heard from many other organisations about that's phased implementation and the fact that it hasn't been fully implemented. I wonder if you could provide any examples of any challenges that this has actually posed in practice.
So the biggest challenges that we would see are the challenges around other professions not having been trained effectively within the Mental Capacity Act. So we would see particular challenges in our interfaces with police. And I know that you've also received evidence from GPs who have also faced challenges in that arena as well. There are also aspects of the Mental Capacity Act around advocacy, for example, that haven't been implemented or haven't been resourced, which we don't want to mirror through this legislation. I think you will see that our position is this legislation is a huge opportunity if we do it right and if we implement it all. Now, we know that we're financially challenged, but what we don't want to do is really squander that opportunity. We need to make the most of it. We know the confidence has fallen in adult protection. We have seen that through the recent inquiries.
Yeah.
This is a chance to change that because we have good practice happening in this area.
And you said there at the start we have heard the issues around the advocacy from many different organisations, so that isn't new, but I think maybe the training piece is something we haven't focused on too much. We have a little bit, but not too much. And so the learning from the Mental Capacity Act is there isn't a sufficient enough training within all sectors.
Yeah, so I think it's the resourcing that's been allocated around the training, the acceptance of things like thresholds when police can come with us in order for us to enforce our powers, which powers we enforce and which powers police enforce, for example, and the work that needs to go into that and then the subsequent training that comes along with it, I think has definitely caused us challenges, and we continue to see those challenges.
Okay, thank you very much.
Okay, thank you. No other members have... Oh, go ahead.
Yes, thanks, Chair. Just in relation to the CCTV, in your presentation there and in your notes, you indicate that you're worried about it having a negative impact on staff morale. Have you considered, or have the staff considered the aspect that it also provides them with protection against any false allegations? And you also say about the audio, that in the absence of audio, you can't get a context for what's actually going on the video. So would you be more comfortable if the CCTV systems did have an audio capacity built into them? Would you be more happy with that sort of a system?
Alan, I think we're certainly not opposed to CCTV, and we can see the comfort that it brings families and how it might make people feel more comfortable within facilities. We certainly see the benefits in that way. Our worry is that it's seen as a silver bullet and a panacea, and that it's going to keep people safe. And we don't believe that CCTV should be the first thing that we look at to keep people safe. So the introduction of audio certainly could provide context, but it also makes it more invasive, doesn't it, for our patients and our service users? So it could also create challenge. We have heard evidence from other people and other views that we really require much more detail around CCTV in order to help us think about the governance and all the things around how we manage it. But ultimately, and I know I said it already, we don't think CCTV keeps people safe. CCTV will certainly help us with prosecutions, but it's our people that keep people safe. We need a healthy culture, safe staffing, well-trained staff, robust inspections, review by statutory commissioners, and a learning culture. It's all those things that keep people safe. And I do worry about our focus on CCTV, and I think the committee have seen that focus as well.
Yeah.
And when we refer to the quality of care, that's all our responsibility to think about that in an earlier stage, so that we aren't over reliant on CCTV. So an example in the Western Trust, our adult safeguarding team, without being required to do so and doing so within our current resources, have allocated an adult protection worker to each independent facility across our trust. So they go out, regardless of the visits from the care managers, work with that home, help them think about safeguarding issues, help them think about prevention issues, pick up issues at an earlier stage in terms of thinking about the quality of care, doing that proactive work to really promote the experience that people are having when they're in facilities such as this. We understand what CCTV has done in terms of prosecutions. Our position is that's too late. We want to prevent harm happening.
Yeah. Appreciate the fact that you say that the CCTV will bring comfort to families of people that are in care, but would you acknowledge that, you know, what I've said about it protecting staff? Would you be prepared to acknowledge that, or do you feel it doesn't offer any protection to staff?
No, we would recognise it can provide that space, that provide what you've said. You know, staff, if you've done nothing wrong, have nothing to worry about.
Yep.
It's balancing all of that against the rights and dignity and the privacy issues for those who are experiencing the care. And but yes, if you've done nothing wrong, it won't be on CCTV.
Thank you for that. Thank you.
Thanks very much, Al.
Thanks, folks, for your presentation today. We had a presentation today on a visit to Antrim Area Hospital, where we listened and learned and were informed of the pilot project there of body-worn cameras, and we're aware that the Western Trust have piloted a project the same. I think started around October, November time from memory. Do you feel that that project will help, or that pilot project will help inform going forward the implementation of the CCTV? Do you think that would be of any benefit?
I think it would. My understanding is that pilot is within the acute hospital sector. And I think you're absolutely right. You know, that project, the pilot, would have to be reviewed, you know, and lessons learned. And I do think as a result of that, you know, those lessons to learn could certainly influence or impact on the discussions in relation to CCTV. I think you're right there. It should certainly influence it. And you know, certainly if my understanding is correct at the moment, you know, staff feel the benefit of it. You know, they feel that it is a protection for them. Is certainly my understanding. You know, but again, and this is purely my understanding in the sense of some of the assaults that have taken place recently. You know, it may not have stopped them, but it obviously certainly, you know, helps with, you know, prosecutions or issues of that nature. And I think, you know, the more that the public are aware of some of the issues that staff are facing. You would hope that it'll become much more of a normalcy for people to say that healthcare staff, including our community staff, should not be assaulted, and that it's not acceptable. And certainly, again, if I'm right, I think the health committee have been very clear about that it's completely unacceptable in relation to that. And I do find that certainly the condemnation coming from yourselves and from the executive is very helpful.
You're also just asked, given that this bill is coming down the tracks, has there been any early assessment of the numbers of staff that you'll be requiring in order to deal with the workload coming out of the bill?
Yeah, we do have, we've been working on partnership with the department and the transformation board, and there is a business case. We refer to that in our submission. There was different options considered in terms of implementation. We refer to that as option 5 in our submission, but really what that means is, as an option appraisal, we were saying that's the kind of quality and level of staffing and training that we would be required to implement this bill in its entirety. So that's with the department, and those costings are available to you.
Okay, that's helpful. Thanks.
Thank you, Danny.
Thank you, Chair. Just to build on what Alan was talking about there, would you also accept that there is a deterrent effect to CCTV being used within premises?
Again, we really want to say that we're not objecting to CCTV. That's not our position to object to it. What we're saying is there's things we can do even before CCTV to ensure that facilities are well run, that people are well cared for, that they experience the kind of care that we expect them to get, that's well regulated by our QIA, by our care managers, and that when families aren't happy, that they are able to report that quickly and it's dealt with quickly. But the points about the benefits of CCTV are well made as well.
Yeah, I mean, I do think you're right. I do think there is a deterrent. You would certainly hope that there's a deterrent, and again, if my understanding is correct, part of the pilot and the Western Trust and the Elton Gavin Hospital is with that, perception in mind, that hopefully it will be, a deterrent if people are aware that, staff are using, body cameras, etc. You just hope that it is a deterrent. But again, I mean, and this is just me reading some of the newspaper reports, etc. Some of the assaults on staff, certainly an ED or with people who maybe have alcohol problems or drug addictions or whatever. But no, you're right. I do think there's an element of deterrent.
There is an important point, though. I think we know that when people want to abuse, and unfortunately those people do exist sometimes within our systems, they will find somewhere to abuse. We're not expecting CCTV to be within private rooms like bedroom or bathroom. So I suppose whilst there is on the one hand a deterrent, on the other hand, if someone wants to abuse, there will be opportunities to continue to do that. So there's something about the public perception and the narrative around CCTV, because it's a balancing act.
Okay, thank you.
Okay, thanks very much. Thank you very much, gentlemen and ladies. Sorry, thank you all of you. That has been very useful, and we really appreciate you, as I say, giving your time to present to us and send us your information in advance of the meeting. So thank you. Okay.
Well, thank you very much. Appreciate it. Thanks. Okay. Thanks a million. Bye.
See you now. Okay, members, just moving on then. So item number 8, oral briefing on adult protection bill from the Patient and Client Council. So can I refer members to our papers at page 64 of the main pack? And can I welcome... Okay, can I welcome Meadhbha Monaghan, Chief Executive Officer, and Peter Hutchinson, Senior Policy, Impact and Influence Manager. So, thank you very much. And we have got your written submission. We're going to hand over to yourselves just for some brief opening remarks. Now we'll go straight to questions from committee members.
Great, thank you very much, and thank you, Chair and Committee, for the opportunity to provide evidence on the Adult Protection Bill today. The PCC welcomed the introduction of the Adult Protection Bill. We consider it a significant step and a clear opportunity to enhance adult protection practices and outcomes for individuals and families. In order to assist committee members in understanding why we are making certain comments on the bill and certain proposals, I'm going to briefly outline relevant aspects of the PCC's role and functions and our work. The PCC is the second smallest arm's length body in the Department of Health in budgetary terms, but we have a significant mandate from the Northern Ireland Assembly through the Health and Social Care Reform Act from 2009. That mandate is to independently represent the interests of the public in health and social care and to seek to influence the system from within. As such, we have a very wide brief, but with a budget of only $2.1 million to undertake that task. Within this budget, we operate at an individual and systemic level, seeking to provide advocacy services for people who have issues in health and social care right across the breadth of those services, as well as engaging the public at a regional level and seeking to influence policy and systems change. Under the 2009 Act, we have 5 statutory functions. We also play an important independent assurance role, which is set out in the HSE framework document. We're one of only 2 organisations that have that role, the other being the RQIA. Our independence is something that we take very seriously in order to promote and support public trust and confidence in the health service. There is an explicit constructive tension in how the PCC is set up. On the one hand, it represents the interests of the public, while on the other hand, we work with HSE bodies within the system to influence change on behalf of the public, and this brings with it opportunities and challenges. We understand our role in the system of governance and assurance as providing the wider public, health and social care trusts, other service providers and the department with information, insights and evidence gathered as part of discharging our statutory functions and direct engagement with the public. In responding to this draft bill, we've considered it in the broader context of what influences and impacts upon adult protection and public safety across the system, including other departmental initiatives and consultations. As you've acknowledged, we've provided the committee with a written submission, which we hope has been of assistance. By the nature of our work and the statutory functions we hold, we're generalists, so we're not experts in the field. We recognise and acknowledge evidence that has been presented to the committee by others so far. To best add value today, we're going to focus our oral evidence on elements relating to the voice of the public and independent advocacy. Fundamental to our role in thinking on this issue is ensuring the voice of the public is heard and woven into the fabric of the bill. This is rooted in the clear message we've heard from the public through our practice and most clearly during our engagement with patients and families in the development of the terms of reference for the Muckamore Abbey Hospital inquiry. We heard that, and I quote, "Responsibility for the failure to act over the years points to systemic failures to hear the voice of patients, families and carers." We note the powerful testimony that the committee heard last week in this regard, as well as the contributions from our own PCC Adult Protection Engagement Platform, and this has shaped our approach to the bill and our work in general. So we welcome the proposal to create an adult protection board within the bill. However, we have engaged with the department to seek agreement that PCC be removed as a member of the Adult Protection Board. We understand that the department accepts this position and will bring forward a related amendment, and we hope that the committee will agree with this approach. The basis for this is that we do not believe PCC's membership of the board is compatible with PCC maintaining our independent challenge and assurance function on behalf of the public and in relation to adult protection, given what the board is tasked to do. Whilst it's not appropriate for PCC to be a member of the Adult Protection Board, we do think that PCC should be a designated consultee of the board. This would ensure that PCC can make appropriate representations to the board in line with our statutory function and challenge role. And we can also play an important role in ensuring the board and the broader experiences of the public are reflected in the board's thinking. Listening to and hearing people and families' experiences should be the first line of defence in safeguarding vulnerable people. To truly listen to understand, organisations, systems and structures must critically be able to demonstrate how listening to experience is contributing to institutional and systemic change, improving the quality and safety of services for others. A key element of adult protection and quality and safety in general is ensuring that governance and assurance structures are appropriate and robust. As we've outlined in our written evidence, there is an element of circular accountability to the proposed Adult Protection Board, in that the majority of board members are proposed to come from the trust and organisations that the board are tasked with holding to account. Therefore, ensuring the voice of those with lived experience of adult protections is heard, listened to and appropriately considered by the Adult Protection Board becomes even more important in the context of the board's constitution. PCC consider the bill can and should be strengthened to ensure that the board is expressly required to engage with and consider the voice of those with lived experience. Equally, the skills composition and the training board members receive will be vitally important to its success. We consider that both those proposals would go some way to strengthening the governance of the Adult Protection Board and potentially boosting public confidence in its role and work. We note and agree on the importance of statutory guidance relating to Part 1 of the bill. We've proposed to the Department, for the reasons we've already outlined, that PCC should be included in the list of bodies the Department must consult with in the development and subsequent review of this guidance. Turning to independent advocacy. We welcome the inclusion and reference to independent advocacy in the bill. However, we do have concerns about how aspects of the bill articulate and deals with independent advocacy, which speaks to a much broader issue about the provision of independent advocacy in Northern Ireland. Independent advocacy is a critical component of safeguarding. The availability and accessibility of independent advocacy assists in creating a culture of openness and transparency and plays a fundamental role in the governance, assurance and in addressing inequality across Northern Ireland. PCC believe that appropriately supporting advocacy services provides a level of assurance that the HSE system as a whole and bodies operating within it are committed to being learning organisations, are committed to meeting their statutory duty of quality, are appropriately invested in the duty of candour, and most importantly, to protecting vulnerable people. As such, we do believe that independent advocacy should be offered and made available to any person identified as a potential adult risk. Independent advocacy should also be offered to family members and relevant persons, and it should extend to Part 2 of the bill to include serious case reviews carried out by the board. Designated independent advocates should also be considered a relevant person under Clause 28. The PCC expects, and we believe the public expect, that organisations providing advocacy services should be independent of service providers, i.e. structurally, financially and psychologically independent. To ensure the integrity of independence, contractual and accountability arrangements for independent advocates should be wholly independent of trusts. The bill is currently written. A Clause 26 requires that HSE trusts will make arrangements to secure independent advocacy, including the arrangements for paying for those services. This fails a key component of independence understood in structural, financial and psychological terms, and it's illustrative of broader issues. At present, each health and social care trust can and does commission their own advocacy services. Whilst they are to be commended for this investment, the unintended consequence is a fragmented provision in which a postcode ladder exists across Northern Ireland. Advocacy services are not commissioned on a regional basis to an agreed or required standard with related training, support and governance mechanisms, and this compounds not only the disjointed nature of provision, but it fundamentally means the public don't know what to expect from advocacy services or how to engage to achieve best outcomes. PCC note that independent advocacy has historically been referenced in health legislation and public inquiry recommendations, from the 1986 Mental Health Order, the Bamford Review, to the Mental Capacity Act, the IHRD Hypernatremia Inquiry, to the recently consulted upon Code of Practice for the Mental Health Order and also the Learning Disability Service Model. In these references, there's clear acknowledgement of the importance of independent advocacy to both individuals and families, but also critically as an assurance mechanism for the whole health and social care system. But despite this, the right to advocacy is not enacted in legislation, and independent advocacy is not currently defined, funded or commissioned on a regional basis. So returning to the bill, it could be future-proofed, for example, to accommodate the possibility of a future independent regional advocacy model being introduced. Whilst we recognise that the evolution of advocacy in Northern Ireland, and specifically the introduction of any regional advocacy model, would be a policy decision and is beyond the scope of this bill, we believe that the bill could be future-proofed to allow for any potential developments in this area, including those which might result from any forthcoming public inquiry reports, whilst avoiding the need for future legislative change. This could be achieved by making the Department responsible for defining independent advocacy and prescribing the arrangements for independent advocacy, including payment on the face of the bill. Finally, PCC has given evidence to a number of public inquiries, including Muckamore and Urology, within which we have articulated and expanded upon many of the points we're making today, and we're happy to direct the committee to that evidence if it's of assistance. Similarly, we're also happy to expand on any aspect of our written or oral evidence on the bill. Thank you.
Okay, thank you very much. Just for transparency, members of the committee received an email from an individual in relation to the PCC. So, I mean, I don't intend, I haven't read it properly, so I don't intend to refer to it. I will be proposing when we come to it in correspondence that we forward it to yourselves for a response. Other members may choose to. I mean, that's entirely up to them. So, in terms of your evidence, I was going to ask you about the issue of yourselves being removed from the board. So you're saying the department are agreeable to that. So can I just ask them what specifically you mean by, I know what a consultee is, but how you think that will improve the work that the value of the work that you do rather than being sitting on the board?
So I think the challenge for PCC is that membership of the board with what the board is tasked to do in terms of being instrumental in oversight and delivery of the adult protection system within Northern Ireland, we would see as being potentially incompatible with our independent challenge and assurance functions. So to spell that out, if we were both sitting on the board in terms of oversight and development of that system, but also potentially providing advocacy support to individuals who are challenged by that system, who have issues in it, there's a fundamental conflict of interest there, as we would see with PCC statutory functions, both actual and perceived. So that deals with the issue around the board. However, we do believe that there is a significant role for PCC in ensuring that the voice of the public are instrumental in the work of the board by being a consultee, both with respect to the work of the board, but also the guidance that is produced by the board and making comment in respect of that. Currently, I believe the position is that it's considered that PCC statutory functions would support that element, but we think that would be strengthened, and I suppose engagement and assurance of engagement with the public would be further strengthened if we were designated as a consultee to the board, which would mean that the board would effectively be required to consult with the PCC in respect of its functions and its guidance. Peter, is there anything you want to add?
I think that covers it all. I mean, it's not a case that being a member of the Adult Protection Board would be incompatible or override any of our statutory functions as they stand, but it would cause additional problems to our independent function and challenge.
And in terms of future-proofing the bill that you kind of concluded on, I mean, you're suggesting that at some point, or the door should be left open for the independent advocates to be paid?
For the independent advocacy and how it's, I suppose, accommodated within the bill to make provision for any future developments in the independent advocacy space, I suppose, is what we're recommending, because we're very mindful of, I suppose, the ongoing developments in the independent advocacy space in terms of how independent advocacy in Northern Ireland is commissioned, funded, regionality of models, how we deal with issues around parity, and we think that this bill could be future-proof to accommodate any evolutions in the future, including from potential inquiry recommendations that might come down the line.
Okay. Fair enough. Thank you. Noah?
Thank you. Philip asked kind of the first question. I think everyone was going to ask that one. But if the board were to not be constituted in its current form, but to be wholly independent, not come under and managed by one body in particular, because we have had other organisations question the independence of the board, would your view still be the same with regards to the PCC role on it?
I think the critical aspect for us is that if you look at what the board is being tasked to do in terms of produce guidance and oversee the delivery of adult protection across the HSC system, that aspect of being potentially accountable for something that people are going to have to implement would cause issue for us if we were having to challenge that at a later date from an independent point of view. So it's as much the functions that it's being tasked to do as to how it is constituted at its core.
Okay, well, thank you. That's helpful. I'm just thinking if it changes, whether that position changes. And we've also heard from other bodies that resourcing and implementation of the bill, is important. If you were a consultee and you still played a role, do you have the sufficient resources, or do you feel confident enough that you'll be able to actually carry out what your duties would be?
I mean, I suppose you'll not be surprised to hear me say that the PCC is under-resourced as an organisation in general, and we already struggle, I think, given the statutory functions that we have in legislation, to fulfil those with the budget that we have. So I think we've been really clear with any amendments that the funding for the PCC is very challenging at the minute.
think that's the same generally across the board, but we have to make sure to ask anyway. You also mentioned your evidence to Muckamore inquiry, so that you could pass it on, but is there anything that you could share here that actually might be beneficial in the context of this bill and the evidence that you gave there? Briefly, I know that you said
I
it's
think
passed on, but
no, thanks, Neil. I think there's probably two things that I would pull out that would be particularly relevant. One is about independent advocacy, because I think when we look at the challenges in Muckamore, and particularly what we heard from families throughout the process of the terms of reference and indeed the inquiry itself, is there are issues in terms of access to advocacy, availability and parity right across the region, both in terms of individuals and families being signposted that, but also having confidence in the independence of advocacy services. And we heard that even through the evidence by Ms Marley from Bryson to the inquiry, in terms of the challenges that they had in both providing and feeling truly independent from with their ability to challenge whenever they were in a contractual and accountability arrangement with the trust. So I think that's why we're making very strongly the point about independent advocacy within this bill, right across the bill, that we have evidence in Northern Ireland around the challenge in terms of independent advocacy and how that's commissioned. I think the second element of that is currently the patchwork provision right across Northern Ireland again is a challenge. You know, when we look at Muckamore, there was 3 different advocacy services providing services across 5 different trusts. There was a lack of a network and a mechanism to ensure that safeguarding issues were repeatedly escalated and that there was oversight in terms of monitoring of trends. I think that issue is going to persist unless that is addressed here. I think that what we heard very clearly from families was the challenge in clear information about adult protection and escalating safeguarding issues, different from and separate from a complaints process. And then I suppose the second thing that I would say is about the integration of and importance of listening to individuals' experiences and the centrality of that to the system as a whole. Because whilst this bill deals with the sharp end of protection, the entry point for all of that is listening to people, listening to the experiences they have and then being believed, and fundamentally that being addressed. And critically, when you think about Muckamore, many individuals, there's a really strong body of evidence about the vulnerability of individuals, many of whom are now dispersed right across our communities and in situations, and I suppose live in situations that are arguably potentially less open to scrutiny and less, I suppose, with less oversight than you might have in a particular setting. So it's even more critical that we do have that support in place where families feel confident and supported to address and raise issues, and that they're listened to and believed at that point.
I think that last bit, you know, the second half was quite helpful for us then to take into consideration, you know, the advocacy separate from any complaints, and whilst this might not be a complaint process but rather a referral, when does the advocacy kick in beforehand? I think that's something actually we can take back and think about that perhaps hasn't been explored yet by the committee. I wanted to ask another question, which was around in your written submission you talked about new offences and around how, I think if I'm reading it right, is your view that there are none, but should there be new offences under this bill? And I wondered, is that just would that be covered for your view by, you know, a duty of candor or the current Hillsborough law that's going through Westminster and hopefully here? Does your view on those offences, will they be covered by that, or is there something separate that you're thinking of?
Yeah, the aspect that we were exploring in our written submission was in relation to the duty to cooperate with inquiries, and looking at it there, the duty to cooperate falls primarily on trusts and organisations, apart from in the relation to police, which refers to individuals. And we were just thinking that is an interesting aspect to look at, and it falls into that realm of a parallel between an organisational duty of candour and an individual, and that would be backed up. And I know there are professional codes of regulation and employment aspects, but would be is strengthened and backed up by the individual duty of candour, which through our previous work with the public is something that they have expressed would be required. And the point on the offences was really saying there's no offence, a specific offence of not cooperating with an inquiry. However, there is a clause in relation to obstructions, so which would probably capture that.
I think it's really interesting that you say that, because we get organisations that are related to either trusts or professional bodies that have a conflicting point of view, but an organisation that is in relationship with and engagement with the public have an opposing view. I think, it's a very important point to raise.
And I suppose at the time we did quite significant engagement around the duty of candour, and we were hearing really strongly from the public that they very much supported that because of their experience, when things go wrong, and I think that's important for us to reflect.
Yeah, and we hear it quite strongly too from the public as well.
The only other thing I was going to add is it's not a simple picture. There are complexities of the commissioning and degrees of separation in relation to that individual aspect, but it is something worth looking in, exploring more.
Thank you very much. I have no further questions.
Thank you. I wanted to dig in a bit into the first question that the chair asked, just about your being on the board as well. Was there any prior consultation with the department before that came out, before the bill came out? Did you have any prior consultation as to what was going to be in it, how you were going to be mentioned in it?
No, I think it's regrettable, and I think we've said this in our written statement, that the department didn't unfortunately consult with PCC as a body corporate in respect of the development of the bill, because it would have been an opportunity for us to raise a number of the issues that we have raised now. That being said, we have had very constructive engagement with the department since then on a number of these amendments that we're proposing, and that is ongoing. We did have engagement throughout the process through our adult protection engagement platform, and I think it's fair to say that perhaps PCC's inclusion as a member of the board was as a result of the interim shadow board that was convened at the development stage, where we had a very clear role in terms of ensuring that the public were appropriately engaged throughout the process. But I think that I would recognise that as a missed opportunity. And I suppose it does strengthen somewhat the point that we are making in respect of PCC being designated consultee to this bill, because whilst I suppose the argument has been put forward that PCC statutory functions in respect of the 2009 Act place an obligation on much of the health system to engage with PCC, in practice we find that isn't always carried out, and at times that is simply not necessarily I suppose intentional, I think, but it purely happens as a small body. People don't always appropriately follow those expectations in statutory functions, which is why we are making the point that being a designated consultee would strengthen that and I suppose address some of the challenges we have experienced to date.
And if I understand you correctly, being a designated consultee, you want that to be written on the face of the bill, but the department differs. Could you explain the difference and what that would mean?
I mean, the current position of our engagement with the department, which is ongoing, is a discussion around whether our existing powers would guarantee us to be able to require being a consultee, and the issue being that we don't want to, like any legislative process, duplicate or override anything. We are at this point don't fully hold the position that it would be a duplication. And it would be probably provide public clarity for the public, clarity for the board, and potentially boost public confidence if we could be written into the bill. But it's still probably a process just to make sure, if that were to be the case, it would be competent. But it's our sort of policy position, if you like, that would be of benefit, given our statutory functions that have a challenge role, but also ensuring the voice of the public is something the board would be regularly considering.
In terms of the independent advocates then, how would you see them interacting with yourself as a group?
I mean, I suppose, and we point to some of this in other commentary we've made in relation to Muckamore and urology. We do think that there is a need, whilst PCC is not looking to take a space in respect of independent advocacy as a whole, we do think, given the statutory function that we have, that any independent advocacy services should be regionally commissioned. They should be commissioned to agreed standards, and that if PCC isn't the commissioner or the provider of the service, there should be clarity for the public about how the roles of independent advocates in whatever space they're operating in articulate with respect to how they engage with PCC. And I think that is a matter to be worked out, but I think that it would be incredibly important that those aspects would be retained.
Another thing, just that you mentioned that you should be separated structurally, financially, and psychologically, or psychologically independent from the board. I can see structurally and financially. What does psychologically independent mean?
Psychologically speaks a lot to the culture and nature of how the culture of advocacy within an organisation, within teams, is implemented, carried out, overseen and encouraged, I suppose. And there's lots of things that feed into that in terms of the training of advocates, the ethos, their understanding of rights-based approaches, the different models of advocacy, etc. So I suppose I would understand psychological independence in very dynamic terms, and it is something that you need to have imbued in the culture of advocacy in terms of how advocates on a daily basis in the space in which they're operating understand and live out that independence. It's a slightly more challenging element to, I suppose, articulate with respect to the financial and structural independence, but that's, I suppose, how I would explain it in terms of that.
I might just add to that, the flip side of that is also the psychological understanding of the independent advocates and the role of people within the system who are working with independent advocates, and respecting that independence is another aspect of it. It's the culture within the system, I would say, as well.
That everybody knows that they are independent.
Yeah.
Yeah, and I suppose it speaks to the value of advocacy within the system. So to Peter's point, understanding within, especially in the area of adult protection, which often operates at the borderlands of lots of other, like mental capacity, rights. It's respecting and valuing the different roles that individuals play within the system, and psychological independence is really critical within that.
Thank you.
Dan?
Thank you. I may have picked this up wrong, so forgive me if I have. You seem to indicate that the membership of the board might be a bit of a case of gamekeeper and poacher all in the one, all in the one space, and that the board might not, as it's envisaged, be as independent as it should be. Am I right?
I think that we are pointing out that there is the potential for circular accountability in the board, given that the composition of the board as described constitutes membership that is to be drawn from the trusts and organisations that the board is tasked with overseeing. Now, that being said, I don't believe that the bill currently prescribes the nature of those members. So, for example, it doesn't set out whether the membership from the trust, for example, is at chief executive director or non-executive director level, and I think that could go some way to assisting some of those challenges. Similarly, I do know that there's provision for lay members within the board, and I suppose another aspect we would reflect upon is that if those lay members are to be drawn from the voluntary community sector, you may again have a situation where representatives from voluntary community sector organisations are sitting on the adult protection board, but may also be providing advocacy or services within the voluntary community sector that they're then tasked with overseeing. So, I mean, we are looking at that and just, I suppose, drawing attention to that. And I think the point that we are making, therefore, as well, is that ensuring that there is a robust mechanism for the voice of the public and for those with lived experience to regularly feed into the board and to hold the board to account in some respects and to have influence there, I think is critical. And I think there's provision within this to make that more robust.
I think it's a really valuable point, because I do think that one of the problems in healthcare is the lack of accountability. So I do think that's a really valuable point, and it would be really interesting if you have any further ideas about the independence of the board and you want to present those. You're one of the few people that have actually pointed that particular issue out, and I just think it's particularly valuable, because when you do look down at it again, it could be a case of the trusts marking their own homework, depending on, as you say, the additional composition. And not only that, and I think if you look at what has happened in some of the trust boards over the last number of years, you see where lay members don't have the same authority, is that a relevant, a useful word, as those who are, you know, coming at it from a position of more power, really. So I do think that that is a really, really valuable point, because we've had enough of people marking their own homework in many ways. For years, the trust told Macklemore parents that there was nothing to see here. It's fine. And I do think that that is a really relevant point, and maybe one that we as a committee, and if you have any further ideas on, those would be really welcomed, about the independence of the board.
Thank you. We'll take that under consideration, and
Yeah.
I suppose the other aspects that we have recognised, and you know, we have made similar comments in Muckmore with respect to trust boards, also is about access to information, the triangulation of information at a board level, where you're drawing your independent assurance from, that isn't just about the information that is fed up through the existing systems, but it comes externally from the board and allows those lay members or the members of the board to triangulate that in a way that allows them to scrutinise in a particular way, but also the training, the composition, the diversity of experience and representation on the board of members is critical to ensuring the success of that. So I think those all need to be in the mix.
It might be something that is really worth looking at because it's all very vague there, and it seems to me to be the same people exercising the same power over the things they've done. Anyway, it's just a really interesting point, and thank you for that. I think that's really valuable.
Could I just ask a question? You used the term there that when you were referring to people with lived experience fitting into the board. I mean, we had people here last week, family members, I'm sure you've seen the session, they're very powerful individuals, and came at it from an angle that brought it back to that very human level. And I made the point at the time that I would dearly wish to see people like that sitting on the Adult Protection Board, if there was a means to do so. Would you support people with lived experience sitting on the Adult Protection Board?
I think we would definitely support the importance of ensuring that the voice of lived experience is there. The mechanism through which that is done, I think, is interesting to consider. And I say that because we have been working with the department and seeking to influence for some time a more strategic approach to public participation, and how the system actually becomes more mature and, I suppose, strategic in the way that we ensure lived experience, and the testimony of family members such as those you heard from last week is infiltrated and integrated right throughout the system, at board level, at service design, commissioning level. That can sometimes be a challenge if you think about it solely in terms of an individual sitting on a particular board, because of course each individual's experience is their experience, and I think what we have found most value from is building structures where people can draw on a network of experience from other spaces, and we have had good experience of this in, for example, the engagement platform mechanisms that we have used, where you're bringing together a cohort of people who can reflect a multiplicity and diversity of views, and then reflect that into the board. So structures that operate to draw that experience up and feed it directly in, I think, is a mechanism by which you could do that in a much more, that would give you a richness of information in a way that perhaps nominating a single individual to a board would not. But I think there's certain scope in Northern Ireland to explore that and to think about a more strategic way for public participation. And also it challenges that fundamental power dynamic that there is in terms of family members and that parity of voice. But yeah, the power dynamic that Dan referred to, but also what we have heard both in the SAI and patient safety space, but also from families in Mucklemore and other spaces, is that feeling of your voice not being equally valued, relevant to other members. And so I think considering the mechanism would address that, to allow that parity of voice to come through, is really important. And it's about giving people more agency in their care for the betterment of the outcomes across the board.
Very good.
Okay, thank you. Thank you very much. That has been very, very helpful. I mean, a number of members have asked if there was the potential for additional information, so if you want to send anything in at a later date, feel free to do so. So thank you.
Thanks for your time.
Thank you. Okay, members, we're a wee bit ahead of schedule, so before we go to our next briefing, we're just going to move on then to item number 10, which is a written briefing from the Department on respite services. short breaks. So can I refer everybody to the briefing on page 124 of the main pack and a response from the department at page 131. So members have any commentary on it? Yes, no.
Thank you, Chair. I understand this is a written briefing, and so only the members here will have access to the information, but I think it's important to highlight that the briefing that we have got here really honestly, from my perspective, looks like the department is now going back on their word to the families of those affected, those on the edge of care, you know, but and not just the families who took part in the Spotlight programme, but actually to so many families out there, and in particular some of the trusts, and I talk about Redwood and Lindsay House. I've written to the department so many times, asked so many written questions about when Redwood is opening, when facilitation can be made for Lindsay House and the transfer between the two. And now we have information here that says that the reopening of Lindsay House as a short breaks home isn't going to happen anytime soon. Despite being told at committee in person, in the chamber, and in many written briefings that was the aim. So how many families is this actually affecting, and what is going on here? We also have questions, I think, is who's leading this issue, because we've heard in informal committee sessions that the lead ahead of the 13 million that was released has moved on, and we've heard that there's no one who has replaced him. So does that mean that there's nobody now, whether it's in the department or SPPG, who actually has their eye on the ball on this issue? I think this briefing's a disgrace, to be perfectly honest, and lets down all of those families and every single one of the families who are on the young people who are on the edge of care. There's a reduction in the number of kids who have been on the edge of care. Is that just because they're not children anymore? They're actually moved on to being adults. I think that we need more information from the department on why this has been able to happen. I'm not sure what's the best way of doing that. I have asked for an urgent oral question to the Minister, because just putting this in a briefing rather than anything else or in person, I don't think is enough.
Yeah. I mean, I totally agree with you, the fact that it is vague. They give you a bit of information but don't give you the detail behind it, so I definitely think that we should be looking for detail. I mean, the issue you've raised in relation to Laurel House is quite important, and it's clear that different trusts are implementing different measures and priorities. So I mean, there's an issue in terms of regional inequity as well that I think we need to get to, because it seems that everybody's doing different things. So other member, Dan, go ahead.
Yeah, no, thank you. I agree on this one. And if you go back to the briefing we had from the parents again, they indicate that actually when the programme was made about the families, particularly in the programme, but they're only representative of a much wider group of families, that their hope was that the 13 million would be for those who were on the very edge or who needed care. And clearly, out of those 5 families, only one family has had that position resolved, which is incredibly disappointing. Now, I understand that things take time, but this is now well over a year since this happened. And I think that the 13 million has been used to augment short breaks or like afternoons away, and they're valuable in themselves. But I don't think, well, certainly it's not what I envisaged that it would be. So I would really like a better breakdown of the 13 million as well. I think that's well worth having, because they now have a year, they've had a year in which to do that. I have some figures for the Southern Trust in relation to the funding that they got, and bearing in mind that the Southern Trust is probably one of the more adequately resourced trusts in relation to this, it still is a huge focus on just the short term and nothing long term, and I think the committee should try to ask the Minister about some of these young people that we're talking about, and I'll be talking to Belfast Trust about another one shortly. They now need to go to adult services, and it's that period of transition that we need to also investigate and what the department are doing with it.
Yeah. I mean, there's a number of issues. We had the briefing from representatives of the families there recently.
Yeah.
And, I mean, you're right. We're all kind of collectively very disappointed that the money wasn't going to where we all assumed it would be going. Now, there are some legitimate reasons for that, but I think a year on, we're all very disappointed. I think there's also a different issue. So I think some of those points we should write back to. I do think that we have the permanent secretary up next week on a different issue, but I think we should make the point to him that some of the briefings that we've been getting recently are lacking potentially the kind of information. You know, it's disappointing that we get a briefing and we're continually saying it lacks information that we need. So we don't want to be swamped with information, but you know, people writing these briefings should know the level of information that is going to be useful for committee members to do the kind of scrutiny work that we want to do. So that's kind of a separate point.
And then we wouldn't have to put in the millions of written questions either through committee or to the business office.
Okay. So are people happy that the clerk writes off again in the back of some of these things and we get a better response back in relation to this issue?
Yeah. Can I ask when then is it in another 3 months' time we have the oral briefing on this?
We will look at the date. The committee did agree to do an event with those on the edge of care as well. So we're doing a bit more work and planning that next week, but it'll be, I think it's around April time. So it is end of March, April, where we'll try and bring those on the edge of care together for a lived experience event. And then, yes, there will be a further briefing scheduled.
Maybe you'll have positive change by then.
Jonathan, they're there. Okay, so we're just going to move backwards then, members, going back to item number 9, which is the oral briefing from the department on the minimum unit pricing of alcohol. Can I refer everybody just to papers at page 95 of the main pack and correspondence received from the Non-Communicable Disease Alliance NI, and that's at page 99. And can I welcome Sir Michael McBride, Chief Medical Officer within the department, and Gary Maxwell, Health Development Policy Branch within the department. You are both very welcome.
Yes,
thank you for coming.
Up the hill, I think you're.
We were way ahead, but
you're way ahead. Yes.
And I can tell you that is the very first time I've ever had to say that in this committee.
Well, I was taking bets earlier that we'll be postponed or late, so I was wrong. Well, thank you very much.
I'm not going to engage in the gambling activity. But anyway, I'm going to hand over to yourselves just for some opening remarks, and then we'll go straight to questions.
Okay, well, listen, thank you very much indeed for the invitation to brief the committee again on the minimum unit pricing of alcohol in Northern Ireland. And just by way of introduction, I'm Michael McBride, the Chief Medical Officer here in Northern Ireland. I'm supported by Gary Maxwell, who will be known to many of you from the Department's Health Development Policy Branch. Now, I know that the Minister has set out in correspondence to the committee his position on this topic in his letter, and I know that members of the committee attended an event in the Long Gallery on the 19th of November, hosted by Chest, Heart and Stroke and the Non-Communicable Diseases Alliance. I thought it would be helpful for me maybe to set out my professional position in relation to the proposed legislation, the evidential basis from a public health perspective, and then for Gary to provide some policy context. And obviously, very happy to take questions, Chair, and any comments that the committee may have. Now, again, it's important to note at the outset that the consumption of alcohol causes real harm to individuals, families and communities in Northern Ireland, and again that will be something that members will be acutely aware of, and that's why, as the 4 UK Chief Medical Officers, we have produced guidance on low risk alcohol consumption, and it's not guidance on safe levels of consumption, as the evidence is increasingly clear that there is no safe level of consumption. and rather the guidance provides advice on levels of consumption that are unlikely to result in significant harm. Now, for adults, that guideline is currently to keep health risks from alcohol to a low level. It is safest not to drink more than 14 units a week on a regular basis. And this reflects the fact that alcohol isn't an ordinary commodity, and its sale is highly regulated for a reason. Drinking above the safe limits can have a negative impact on people's physical and mental health, on family relationships, on our local communities, on crime and community safety, and on our economy. Research commissioned by the department, and Gary will expand on this, estimates that the cost of alcohol misuse costs Northern Ireland up to £900 million every single year. In addition, there are unacceptable health inequalities in this area. Alcohol-specific mortality in our most deprived areas is almost 4.5 times that in the least deprived. The University of Sheffield's September 2025 report entitled Estimating the Burden of Alcohol on the Health of Northern Ireland estimates that there are at least 676 alcohol-related deaths per year. And this takes account of both deaths that are caused solely by alcohol consumption, which makes up about a half of those, and a third of those are due to alcoholic liver disease, and those where alcohol plays a contributory role. The report also demonstrates that the substantial contribution that alcohol makes to cancer risks, with 127 people dying each year from cancers related to alcohol consumption. The report also points to the 7,426 alcohol-related hospital admissions each year at a cost of some 19 million. However, hospitals are often the very last place to see the harm caused by alcohol. We know that harmful use of alcohol brings distress and suffering for individuals and families, particularly children in homes where parental alcohol use is taking place, and such harms are extensive, and the trauma can span generations with negative physical and mental health outcomes. Earlier modelling shows that alcohol-attributed deaths and hospital admissions are concentrated in increasing and higher risk drinkers, with 76% of all deaths and 61% of all of the hospital admissions that I've just referred to due to alcohol coming from the heaviest drinking 3% of the population. And from a wider health perspective, alcohol, as you will know, is a group 1 carcinogen, like tobacco. It is causally linked to 7 types of cancer, and heavy consumption also weakens the immune system and reduces our ability to cope with infectious diseases. Now, alcohol has long been an accepted part of Northern Ireland's social and cultural life. 78% of us consume alcohol, and perhaps to some extent we've become desensitised to the harm it can result in. However, to put this in context, each year alcohol causes twice as many deaths as illicit drugs in Northern Ireland, which is a very sobering statistic. And in health, regrettably, much of our activity is inevitably focused on addressing the harms of alcohol use after the damage is done, and prevention of those harms is a much more difficult area to navigate. The evidence, however, strongly points to pricing initiatives, and particularly minimum unit pricing, as providing one of the best ways of preventing harmful alcohol consumption. Now, the support for minimum unit pricing legislation is evident amongst leading public health experts. The WHO, in its report, No Place for Cheap Alcohol, outlines the potential benefits of minimum unit pricing and recommends minimum unit pricing as a cost-effective way of reducing alcohol consumption and harm when combined with other policies to reduce harm. The WHO also notes that policies that increase alcohol prices delay the initiation of alcohol use amongst young people in particular, and delay the progression towards the consumption in young people of larger amounts of alcohol, and reduce heavy episodic use of alcohol among young people. Again, a very important benefit of this legislation. There is also clear evidence of minimum unit pricing effectiveness from various modelling and evaluation studies, particularly in Scotland, where the legislation was introduced in 2018. This led to a 3% reduction in alcohol sales, the vast majority of that in the off sales, saw larger reductions in drinking among heavier drinkers and led to a 13% drop in deaths wholly attributable to alcohol, and that's estimated to be some 120 deaths per year. Now, the Minister regularly raises the health inequalities that we continue to see in relation to alcohol-related harms. I know this has been a topic that the Health Committee has considered in various guises and its impact. A recent NISRA analysis showed that in people without formal qualifications, who make up about a fifth of our population, they made up 41.4% of alcohol-specific deaths. If we look at economically inactive individuals, who make up about a quarter of our overall population, there was gain and overrepresentation in alcohol-specific deaths of some 50.5%. And the strongest predictor of alcohol death is unemployment. And again, if we look at deaths in those in social housing residents, again, that amounts for 35.5% of the deaths. So this is a huge disproportionate impact on people living in socioeconomic deprivation. In Northern Ireland from 2015 to 2022, in the 15 to 64 age group, alcohol-specific deaths were the fourth leading cause of death, accounting for 9.6% of deaths in males and 7.8% in females. And I mean, I've spent many years working in the health service, and I've witnessed, as my colleagues have at first hand, the harms of alcohol. And I know that in your constituency work, again, you will be only too aware of those harms. But even for me, those statistics are truly shocking. Now, the Minister regularly references the need to reduce demand on our health service, and in support of this, clinicians such as Roger McCrory, hepatologist and alcohol lead in the Belfast Trust, the Royal College of Psychiatrists have also voiced support for minimum unit pricing. And again, the committee I know has taken evidence previously and may wish to hear from these important voices again directly. From my professional perspective, clearly minimum unit pricing isn't a panacea for all harms related to alcohol use, and there continues to be a need for investment in services, particularly for those with alcohol dependency. However, in my professional view, minimum unit price is a highly targeted policy and an opportunity not to be missed to make a meaningful difference which will bring benefit for the health service, but more importantly reduce the harm to individuals, families and communities across the region. I'll maybe now hand over to Gary, Chair, if you're content for a few comments.
Just very briefly, I think from a policy perspective, so I'm Gary Maxwell, I head up the Health Development Policy branch in the Department, and I look after preventing harm, empowering recovery, the substance use strategy from a strategic point of view. And as Michael said, I think, while our focus often turns to drugs, the strategy recognises that actually alcohol is our preferred drug in Northern Ireland, and actually causes more harm than those illicit and illegal drugs. So we really make the case through the strategy of the need to tackle alcohol's availability and accessibility through price and other mechanisms, as well as improving treatment and support for those who need it most. Minimum unit pricing for alcohol is a population health measure that sets the minimum price that could be charged for a unit of alcohol, which is about 8 grams or 8 milligrams or 10 mils of alcohol in any alcohol product in the on or off trade. It ensures that alcohol drinks cannot be sold lower than this price, the minimum unit price multiplied by the number of units in the product. As Michael has set out, research and evaluation shows that this targets very cheap, heavily discounted or loss leader products such as own brand spirits, high strength beers, white ciders, which have a very high alcohol content and tend to be consumed by the heaviest drinkers. MUP is unlikely to affect the prices in pubs and clubs. For example, at a 65p MUP, a pint of Guinness could not be sold below £1.50 or a 13% bottle of wine below £6.34, and you'll not find those anywhere in our on-trade at the moment, so you can see really the impact is on the off-sales. MUP has been under consideration for a number of years, and myself and Michael have talked about it for a number of years. And given the evidence base and support that it's had, and preventing harm, empowering recovery included an action to consult on its introduction in Northern Ireland. This was undertaken and a summary of the consultation responses published in 2023. At the same time, we recommissioned the University of Sheffield to undertake an updated modelling using health data and price data in Northern Ireland. And again, this suggests that MUP would lead to a reduction of alcohol-related harm, including deaths, hospital admissions, alcohol-related crimes, and lower rates of absenteeism and presenteeism in the workplaces. Obviously, the impact depends at which level you set the MUP at. So just quickly, by way of an example, a 65p MUP is estimated would reduce alcohol consumption by about 8.5%, with the majority of that coming in increasing risk and higher risk drinkers, and that is absolutely the population that this policy targets. It increases spend only by 1.9% for moderate drinkers, 2.3% for increasing risk drinkers, but because of the way it works, it actually reduces spend in high risk drinkers because they're reducing the amount they spend on the products. It would reduce alcohol deaths by about 82 per year and admissions to hospital by 3,482. Crime is estimated to reduce by 3,188 offences per year, and absences down by around 60,000 days per year, which could result in healthcare savings of around 117.4 million over 20 years. And it is important to note the modelling predicts that actually it takes time for the full benefits of MUP to accrue. The fact that we've seen benefits in Scotland actually is a really positive sign in that that's early, and it's actually that longer time frame that the harm really takes to accumulate. As Michael says, we have really good evidence from the 5-year evaluation in Scotland, the evaluation in Wales, and since the work that's been done in Ireland since it was introduced in 2022. These all show that MUP has had an impact on the sale of cheap, high-strength products, particularly in Scotland, where we've that really comprehensive analysis and seen an estimated reduction in alcohol attributable deaths in comparison to what would have occurred in the absence of MUP. Importantly, and often we hear counterpoints against MUP that it'll increase crime, people will move to using other substances. There is no evidence of that in the Scottish evaluation or the Wales evaluation. Not to say the policy's perfect, and there are pieces in there that need to be picked up, we need to think about, particularly for dependent drinkers who are a slightly different category, but they haven't shown those negative impacts. There's also evaluations in other places around the world. Now I would say Canada, Russia, they show positive, but the system of alcohol licensing is slightly different, so you need to take that into account, but there are those positive things. So a full options paper was considered by the Minister, who has subsequently set out he believes minute pricing is a key mechanism to reduce alcohol-related harm in Northern Ireland. As a cross-cutting issue, legislation to bring this forward requires the support of the Executive and obviously subsequent debate in the Assembly. It's important to acknowledge that timescales now are very tight for progressing this in the current mandate, given where we are. Should the Minister be unable to take this forward, he is required to make a statement to the Assembly by the 6th of April 2026, based on the Section 21 of the Licensing and Registration of Clubs Amendment Act 2021 as to why this has not been reasonably able to do so. However, the Minister has set out that it will continue to support the introduction of MUP as a critical step towards reducing alcohol-related harm, and I think particularly, as Michael has said, those health inequalities that exist around alcohol in Northern Ireland. Thank you.
Okay, thank you very much. That has been very interesting, very thorough and very informative. I'm trying to calculate how long I've been an MLA here, but in whatever length of period of time that has been, I don't think I have seen a piece of potential legislation where kind of the evidence, the science, the benefits has been as positive as what you have alerted us to today, and through all the evidence. I mean, I've read the study from Sheffield, I've engaged with other groups, and I mean, I take what you're saying, that there are some things that need to be worked through, but on the whole, the evidence where it's been introduced, Scotland, Wales, the South, has been really positive in terms of dealing with the issues which it is meant to do, which is having an impact on our alcohol dependency, which is about reducing hospital admissions, which is about having an impact on crime and our court system, our economy through lost days at work. I mean, I think it was interesting today, the committee visited Antrim A&E Hospital to talk to nurses about violence and aggression against nurses, and the comment was made that not always, but in a majority of cases, this is something that is coming from people who are intoxicated or of heavy levels of alcohol and drugs. I mean, the Minister, and I applaud the Minister for his determination to tackle health inequalities. Well, I mean, here's a piece of legislation which is clearly shown that would have an impact on the most socially deprived areas of our society. Gary, you read out what I have put in front of me here in terms of the Minister's own words, and he states, I'm going to repeat it because I think it's important, I have therefore been very clear that I believe that the minimum unit pricing could be a key mechanism to reduce alcohol-related harm in the north and to address health inequalities that exist in this area. And Dr. McBride, you said that it was an opportunity not to be missed. So I think the key question for us as a committee is, why are we sitting here talking about something that we want to see rather than something that we should be seeing coming through this committee and the floor of the Assembly in terms of doing good for our population?
Well, I mean, I think you've very aptly highlighted the evidence base. You know, the impact that this is going to have is a very targeted intervention which will specifically target problem drinkers and will greatly reduce the pressures on our health service, the cost to our health service, but also the individual impact on individuals, families and communities. It is evidence-based. As Gary has said, it will take at least 10 years before we see the full impact, but the fact that we're seeing after 5 years these impacts in Scotland, even with the inflationary sort of erosion of the 50p unit price that they put in place back in 2018, which have now increased to 65p on the basis of the robust evidence that they're seeing, that early evidence in terms of real world experience is very reaffirming. I mean, I think I would equate it to the tobacco and vapes bill, which again we secured the support from the committee and indeed from the executive in taking forward a legislative consent motion to basically ensure that we protect our young people from the harmful impact of tobacco and vapes. Alcohol is another group 1 carcinogen. The harms we've summarised. I mean, obviously, as Gary has highlighted, it will and does require, because it is cross-cutting, it requires executive agreement. I think the Minister has been very clear. While I'm not party to executive consideration and discussions, the Minister has been clear that he has not, at this point in time, secured executive agreement to this. We are essentially in this mandate now running very tight for time. It would still be possible to get through in this mandate if we were able to secure executive agreement, but again, I think that obviously is the issue which is proving challenging at this point.
Well, just in terms of the process then, Gary, because like I say, I mean, I'm kind of a bit astounded that this wouldn't have wholehearted executive support, so I think it would be interesting to hear the arguments for not allowing this piece of legislation to go forward. So if the Minister doesn't get executive support, you're saying he therefore comes to the Assembly, gives the reason for it, and does that open up a debate?
So he has to make a statement to the Assembly, which
Okay.
I assume would then allow questions and and answers after that as part of that process. Obviously, he will set out where he's got to with the process, and I think he would probably set out. He thinks if it isn't possible in this mandate, it's certainly something we should return to, given its evidence base. But that's the 6th of April. Deadline he has to work to.
And I was just looking back at some of the previous missed opportunities in relation to this. Gary's alluded to this, I first started advocating this from public health intervention and the evidence base for this over 10 years ago, 12 years ago now. I did media interviews at the time. We were in advance of other parts of these islands in terms of proposing this for many reasons. We were not able to take that through the executive, because obviously for quite a number of those years there was not an executive in place. This to me does feel like a potential missed opportunity. If we had put in place the legislation 10 years ago, you can do the maths as well as I can in terms of the lives that would be saved, the harm that would be prevented, the costs that would have been avoided to our health service. We do still have time in this mandate, but it is now extremely tight, and I think that it would be very regrettable if this opportunity were to be missed. And the evidence base now is even stronger than it was 10 years ago.
I mean, I would go stronger than saying it would be a missed opportunity. I mean, I'm the chair of the Health Committee. All of us here are trying to help the minister help our population live a healthier and better life, and we've been presented with a clear opportunity to do that. I haven't got the agreement of the Health Committee to say it, so I'm going to say this in a personal perspective, that I think it would be much more than a missed opportunity. I think it would be a derogation of duty of all of us in this Assembly if we didn't see this legislation coming before us before the end of this mandate. Danny?
Thank you, Chair. As a nurse of many years and worked in the health service, not as many as yourself, Michael, but certainly been there quite a few years, I've seen the effects of this in the health service on the people who have had these conditions and had multiple injuries related to alcohol as well, and the effect in A&Es when people arrive intoxicated. And we've met with staff today who talked about the violent assaults and the high level of violent assaults on healthcare staff that are related to drugs and alcohol. So there's a myriad of problems here that, in my view, that this would help. The evidence, in my view, is very, very strong. And I attended that event in November, and again I found the evidence very, very convincing, and I'm absolutely convinced by the evidence that that this would have a positive effect in Northern Ireland. I've met with lots of groups and know the Non-Communicative Disease Alliance, and a lot of those other health groups as well that have highlighted this would as having a positive benefit in Northern Ireland. What's your view of the arguments against this? Now, looking at this, I can't see anything that's obvious jumping out at me. Is there what is your view of the arguments against this, and how do you rate them?
I mean, I've engaged with a range of parties and stakeholders in relation to this. I mean, all of the evidence, all of the research, all of the modelling points to the effectiveness as a targeted, proportionate measure to address the harms caused by alcohol. I have not seen or heard in any of those discussions or discourses any compelling case made as to why we would not introduce the legislation, subject to executive consideration, approval and debate in the Assembly, of course. I think that I think, just building on the Chair's comments, that where we have evidence of an intervention that is effective and a building body of evidence of the effectiveness of that and the impact that it has, I agree we have both a professional, as a doctor and as former nurse, we have professional responsibilities to advocate for that. But I think there's a moral imperative that we ensure that we take those actions to protect those that are addicted to our consuming harmful amounts of alcohol, and the knock-on consequences for their families and their communities, and the wider consequences in terms of health and social care cost to our criminal justice system and to the economy. So I agree with the Chair. There's a moral imperative, in my view, to take this legislation forward.
I think just some of the arguments put forward against it can be, one, I think we mentioned this earlier, dependent drinkers won't stop drinking based on the price. I think it's clear the target of this is not dependent drinkers. Yeah. Dependent drinkers need treatment and support, and actually it's harmful and hazardous drinkers. But I think Colin Angus at that event made a really good point. What it can do is stop creating the dependent drinkers of the future by intervening by harmful and hazardous drinkers, and I think that's really important to note. I think the other concern people raise is about the impact on lower income, and I think the point we would make is actually those in lower income people who drink are substantially the brunt of the harm currently, and actually this is helpful to them in terms of reducing that harm that they face. It's actually very targeted, much more targeted than a tax, which is across the piece. And the other thing we hear is that it obviously impacts moderate drinkers, but the modelling actually shows really limited impact on moderate drinkers. But actually, reducing some moderate drinking is not a bad thing, looking at the evidence as well. But really, those kind of increased spending of 1.9% is very limited in terms of the impact.
I mean, I think the argument, and undoubtedly we're all acutely aware of the cost of living crisis and the impact that is having, but I think there are some spurious arguments made that actually this would increase costs of alcohol, and people would switch from buying food to buying alcohol. The evidence is that in areas of socioeconomic deprivation, people spend less money on alcohol, buy less alcohol in general. But actually, if you look to problem drinkers, there's a disproportionate number of people who drink at harmful and hazardous levels living in areas of socioeconomic deprivation, as we've highlighted in the statistics. So I think it's a misunderstanding in some aspects of the evidence and the impact that it will have. That that somehow or other this will cause a disproportionate impact on people who drink at moderate levels. It will not have that impact. So I think it's perhaps a misunderstanding of the evidence.
I've heard it claimed that people don't believe the evidence from Scotland. And in terms of public health policy, how strong do you see the evidence from Scotland as being?
I mean, I think that, as we said already, that it will take 10 years, and you know, we're very clear on that. It will take 10 years before we see the full impact. The fact that we're seeing 5 years into the legislation in Scotland, you know, a 3% reduction in alcohol sales, over 4% reduction in hospital admissions, and a 13% reduction in deaths. That's 120 fewer deaths a year. That is impressive after 5 years of introduction of a piece of legislation. I mean, so that is compelling. If we look at the Wales, again, showing positive trends in the right direction, not as robust data as in Scotland, and looking south of the border, in the south, again, they've seen from in 2022 compared to 2019, although the pandemic was in the middle there in terms of you know, behavioural change, etc. They've seen a 5% reduction in alcohol sales, and some early data from the Beaumont Hospital, which again is early data showing a reduction in ED attendances directly as a consequence of alcohol. So I think the evidence base is compelling. It's strengthening. I think it's likely to strengthen further. You know, I do think that certainly I'm sufficiently convinced by the evidence that I have read to recommend to the Minister that this is legislation which I would commend to the Executive.
Just to pick up on that, I know some of the concerns were raised about an issue that MSP referred some of the reporting of the Scottish evaluation to the UK Statistics Authority, and it's, I think, just worth quoting. Sir Robert Choate responded to say, "We consider the findings of the final Public Health Scotland report are communicated clearly and impartially." So they did change some of the wording. Yeah. I think when you talk about deaths, you can't say somebody definitely didn't die. Do you know what I mean? You have to estimate that person would have died because you don't know what the wider circumstances is. So there was some clarification around the wording of the estimated number of deaths as opposed to being very directive. That's been picked up in the language. And I think just in response to that, Professor Sir Michael Marmot, Professor Sir Ian Gilmore and Professor Martin McKee all wrote in support of the Scottish evaluation. So, you know, a range of people there who are sort of public health experts writing on the basis, and I know Ian presented to the Social Development Committee before. That's how long ago that was with
10
yourself?
10 years ago, and again to this committee. I think Professor Ian Gilmore and myself presented evidence to this committee, I think, you know, 10, 11 years ago on this very issue and on the evidence base. So, I mean, the evidence, I think, at this point in time is irrefutable in terms of the benefits associated with this.
The evidence is irrefutable.
Yeah.
Thank you. Thank you.
Just anecdotally, I was at Nicola Sturgeon's book signing at an event recently, and she was asked from the floor about what was her best achievement in terms of policy, and she mentioned this piece of legislation because of the impact that it had in saving lives. Scotland, not everybody may agree with Nicola Sturgeon's politics, but I thought that was a very impactful statement in terms of all the work that went on in Scotland. She was picking this piece of legislation out as well. Nuala?
Has this actually been brought to the Executive yet by the Minister?
Yes, and again, I think there have been 3 papers, my understanding, have been presented to the Executive. To be honest, I don't attend meetings of the Executive, so I don't know to what extent it has been considered.
So it hasn't gone to a vote, it's just not got on the agenda. Is it another issue that is being blocked, or has it just not?
Again, I'm not party to the details. I know that there have been 3 papers have gone to the Executive. I don't know to what extent. I know there has been discussion. I don't know how extensive those discussions have been, and I know there has been correspondence from the Minister and indeed from other Executive Ministers to our Minister in relation to the proposed legislation.
And within the papers that have gone to the Executive, have they contained that irrefutable evidence, as you describe it, within information?
I've certainly provided my advice to the Minister, and obviously any papers to the Executive would include the advice that I've provided to the Minister.
Before the committee, we had the APG all-party group on stroke, and Colin Angus from Sheffield University was also there presenting some of his findings. And one of the things that I found interesting was that you know, this wouldn't have an impact on hospitality. Because of the impact on actually, like for a pint, as a pint, for example. But that also it would generally have an impact significantly on items such as cider. Those who are from more low-income communities and are already dependent on alcohol. Has that been one of the arguments? Because I think it's really important to highlight again how it is not targeting dependent, it's actually targeting the future. And if this was to come through, do we see that there would be additional support in terms of region-wide for those who are already, dependent on alcohol? Or
yeah, so certainly, we would make the policy aim clear, which is to reduce the harm in increasing and increased risk drinkers, because that's where the evidence is quite clear. Dependent drinkers, as I said, is a different category and require different supports. Not to say that we couldn't stop creating a cohort of dependent drinkers in the future too. So obviously that's the policy aim around that. So no, that's absolutely clear. And what's really important is that MUP is not a panacea. It by itself will not solve our alcohol problems in Northern Ireland. We are taking forward a programme, and I think you got an update recently, a written update on our wider substance use strategy. And so within that is a programme of work to look at how we improve our services. Obviously that's difficult in the budget environment that we're in, but I think that's really important. And if you look at the work being funded under Peace Plus, particularly around the community detox approach, I think that's really where you start to get the impact of bringing detox services, treatment closer into communities, to get people to access those rather than going into specialist services. So there's a piece of work that will be happening around that anyway, but that's helpful then in targeting those folks who are particularly dependent, because MUP is not the solution for that cohort.
I think you make a very valid point, because I think that's part of the confusion and the misunderstanding, is that somehow or other minimum unit pricing will actually be of benefit to people who have alcohol dependency. It won't. I mean, as Gary has said, people with alcohol dependency need treatment and support. We need to do more in terms of our services. There's been a recent review of alcohol treatment support services that was recently published in terms of the commissioning framework for that and the implementation plan, as Gary has alluded to. And we need better integration between community services, community addiction services, detoxification services, and mental health services. That is challenging the current resorting climate, but certainly there's more that we can do to target and support individuals with alcohol dependency. And a key element that we would be monitoring, subject to executive consideration and approval of the legislation, will to be monitoring the impact on those with alcohol dependency, because we would not wish there to be any negative impact, and that's something that we would keep a very close eye to.
Thank you. And I just think it's just important to highlight that there was stats from NISRA that direct alcohol could be correlated to direct alcohol deaths, over 341, but they aren't the true figure. It's actually much, much higher of deaths that are related to linking back to alcohol. And I think it is important, and just to put on record, that the Alliance Party do support the introduction of minimum unit pricing, and hopefully it can get executive approval.
Well, and certainly with the committee's support, hopefully, the executive will look favourably on the proposal.
I would be suggesting that we write to the executive to support the minister in the aftermath.
Okay, I missed that.
Yeah, sure. I think some of my questions really have been answered by the speakers, but this 3% of the population are the core drinkers. I think you can really separate them from this legislation. It's a different problem. You're talking about the ongoing care for them and the help, but putting the price of drink up ain't going to make a bit of difference to those people, because they're so dependent on alcohol. My family business, we over the years sell cigarettes and tobacco, and cigarettes go up £1 a packet, and the addict will come in and say, "Oh, there'll never be another cigarette in my mouth," and a week later they're in paying the £1 and buying the 20 cigarettes. But what you hope is that it will stop young people taking up the habit. So I think this legislation really is, it's future-proofed, it's pitched at generations, and the real benefits of it, you said, Professor, 10 years, it will take that amount of time, but it's well worth starting the process and getting it going. But and obviously you've said that you're not really privy to what goes on in the executive, and no doubt there would be confidentiality issues as well. But I think we're all maybe wondering, is it a case of really compelling counter arguments been made in the executive, or is it just a case of some people maybe quietly obstructing the legislation for whatever reasons? But no doubt, come the April, we may get those. Hopefully, we'll not. Maybe the legislation will go ahead, and we'll not be getting a negative statement from the minister in April. But keep our fingers crossed. But thank you very much.
Well, no, I mean, I think we have an obligation to ensure that we answer any concerns that ministers have in relation to the legislation. I mean, that's a responsibility on us as officials, and if there's points of clarification in relation to the evidence base, very happy to do that. I think that quite reasonably ministers will have questions. That's the role of ministers, to challenge and to test and to question. And it's our responsibility to answer those questions as comprehensively and as fully as we can, and to explain and interpret the evidence, or indeed if there are gaps in the evidence, to seek to provide those answers so that we can ensure that ministers are making a full are fully considering the options. So again, I mean, as a pathological optimist, hopefully with the support of the committee, there still remains an opportunity for the executive in this mandate to proceed with the legislation. Hopefully that will be the case.
Good.
I mean, very small question.
Very small question. I know the Minister is very much strongly in favour of this and has mentioned it many times. From what you've said, answering other questions, there have been 3 attempts to bring this to the executive. 3 papers have been presented to the executive.
I think that's my understanding. Again, I'm not party. I mean, I know that I have provided advice on a number of occasions, and obviously, but I'm not party to executive consideration or discussion, and it wouldn't be appropriate for me to comment on that.
3 papers have been presented, and they've all been. None of them have been put on the agenda.
Well, I say that's not. I mean, I'm not saying that because I honestly don't know the detail of the executive consideration of this matter. I really don't, and it wouldn't be appropriate for me to speculate or to comment on that.
Certainly, repeated attempts by the minister to bring this forward.
Well, I think you've highlighted how keen and committed the minister is to this, and how convinced he is by the evidence base and the advice that's been provided to him. And I think he's publicly stated that as well. I mean, he restated his commitment at the event which you attended on the 19th of November in the Long Gallery, and a number of other MLAs attended. So he is absolutely committed to getting this one through and over the line in the time that remains in this mandate.
Okay, thank you very much. That really appreciate it. It's been very helpful. Okay, members, so just given that conversation, and I mean, it's clear the Minister wants to bring this and isn't been allowed to bring it, so I'm going to suggest as a committee, the Health Committee, that we write to the Executive offering our support in supporting the Minister, get this piece of legislation to the floor of the Assembly. If there are issues that we aren't aware of, or certainly I am not aware of at this moment in time, why the bill shouldn't be then, they should be given the same scrutiny and opportunity through the legislative process to make changes. So I'm hoping that we can write to the Executive, as I say, and offer the support of the Health Committee and offer the support to the Minister in getting this legislation through.
Can I just add to that, just with that presentation, incredibly strong, and highlight within that the Chief Medical Officer considered the evidence to be irrefutable, and make sure that the committee had heard that. Thank you.
Okay. Moving on then, correspondence. Can I refer members to correspondence in the main pack, page 149, including correspondence index at page 150. So just before we suppose we give agreement to that, at tabled papers we also have received a number of pieces of correspondence. At page 5 of table papers, we all received a letter in relation to the Patient-Client Council in advance of the Adult Protection Bill. I got it briefly, scanned it, didn't have an opportunity to read it in advance of that. So I don't know if anybody's any comments. I was going to suggest that we forward that person's concerns on to the Patient-Client Council for comments. People can tell me that. Okay, Yep.
11.2, are we doing correspondence now?
Yeah, go ahead.
The correspondence just from the department, just on pharmacy issues. Could we share that with CPNI?
Absolutely.
No problem, thank you.
And also then there's correspondence in the table papers formal complaint on ADHD services. So we got that, but it was also shared with the department. Okay, so we don't need to send it on to the department, but could we ask the department maybe to give us commentary on it? I think it would be useful for members of the committee just to know what the department's thoughts were on it, or if we could be copied into the response. Are members content then with the rest of the suggested actions in the correspondence index at page 150? Okay, thank you. Item number 12, forward work programme. Can I refer members to the draft forward work programme, page 187? Members content with that? So, everybody aware, we're meeting at the Shankles Women's Centre next Thursday. We're meeting the Permanent Secretary, and there's an opportunity earlier to engage and get a tour and have lunch. So, if people can just inform the committee staff. No?
Policing board, so I will be unavailable.
Okay, that's no problem. Okay, any other business?
I have the police authority in the morning, the policing board.
Okay.
I'll certainly endeavour to be there for 2 o'clock for the meeting if I can. I'm sure other members may be similarly affected.
Yeah. Just on any other business.
Go ahead.
So I was sort of listening to the debate over the decrease in waiting lists, and that is very, very welcome. But I still think that there are some questions for us to ask around that. And when Professor Taylor was at the committee, or the informal committee, I did ask for specific numbers on, the number of people that were on the list at a particular point, the reduction, and specific numbers around the 200,000. Is that 200,000 people, or is that 200,000 particular things that have scans or whatever has been done? I was talking to a guy today, and he said, well, in the last 2 months I've had 3 different appointments. And he made the point that they were reasonably quick, much quicker than he had anticipated, which is brilliant. But it was 3, so how is that 200,000 calculated?
So because we've discussed this, we've sent a number of questions off to the department. Could we CC members just into the actual questions that we have asked? Because I think that might have been one of them.
Was it?
Covered partly, so it was,
okay.
But not
in the
as full
detail.
as that, because I think the 200,000 we came this week.
It only came out this week. Okay. Just so that we know, is it 200,000 particular like scans or whatever, or is it 200,000 patients?
I do think that we should just CC us as members, and just in terms of what we've wrote, and then what we further write in relation to the announcement this week.
And plus the sort of starting and where we are now figures, because I think that is really, really important.
Okay, everybody content? So date, time, place of next meeting, next Thursday, Shankles Women's Centre. The official meeting starts at 2 p.m. Meeting adjourned. Thank you all.